Good afternoon. My name is Susan Edgman-Levitan, and I'm the Executive Director of the Stoeckle Center for Primary Care Innovation at Mass General. And I'm very excited to be here today with this wonderful panel because I know we're all going to learn a lot about what I think of as some of the more interesting, effective, and disruptive ways of serving the needs of our patients, our populations, as we move forward in a world where we have a tsunami of people like me who are getting older and are going to need much more complex care. And we also have universal coverage pretty much now, which has really taxed the primary care world. And we also have challenges with training enough physicians, nurse practitioners, PAs, and other health professionals that can serve our population. So I'm very excited to hear today from our panel about the way that they are approaching these issues to provide high-quality, accessible care. So with that, we're going to start with a brief description and overview of each company, and then we're going to have a dialogue, and we'll leave time at the end for questions. So our first speaker will be Dr. Mark Seraly, Roy Schoenberg, Pat Basu, and Harry Leider from Walgreens. So Mark, why don't you go ahead and start?
Good afternoon. My name is Mark Seraly. I'm the Chief Medical Officer and founder of Iagnosis, and we're a virtual health company based out of Pittsburgh and developers of DermatologistOnCall.com. And basically what we do is we facilitate connecting patients to a board-certified dermatologist and provide the dermatologist with all of the telemedicine tools to diagnose, treat, and counsel patients using this virtual office platform. So the biggest pressure point, of course, is getting in to see a dermatologist. A 34-day wait on average across all markets. And what we've been able to do with our network, which is now in 31 states and growing, is cut that time down to 11 hours. So that's clearly a start. We aim to do better even than that, but that's where we are with dermatology.
Terrific. Good afternoon, everyone. I'm Roy Schoenberg. I'm CEO of American Well. We're actually a Boston-based company. Been in the business of delivering telehealth for about 10 years, which is absolutely forever in this domain. Started our lives as mostly focusing on delivering quick access to physicians to members of health plans, and have been focused on health plans for a big chunk of our life. Started, interestingly, with Blue Cross Blue Shield of Hawaii. Those of you who live in Boston understand why we made that choice. But then, since then, it has grown, pretty dramatically. Today, we serve over 30 Blue Cross Blue Shield plans and many of the large nationals, in some cases together with, with Pat's company. And if anything, I can say that over the last couple of years, we've seen, beyond that growth, which has been really spectacular, we have seen the rest of the pieces of the puzzle of healthcare delivery kind of fall into place in terms of embracing telehealth. And this is really a very, very new thing, not only the different medical boards and medical associations, but we've actually started working to a great degree with a lot of the health systems out there and the provider organizations, and they have been by far, in the last 2 years, the most formidable power in terms of embracing telehealth in a lot of different ways that when we went to search for the coconuts in Hawaii, we never anticipated. So it's great to be here. Thank you.
Thank you.
Good afternoon, everyone. Pat Basu, the President and Chief Medical Officer of Doctor On Demand. Just by way of introduction, I used to be a physician at Stanford University. Also, I taught health economics and policy there for 3 years. And I took a leave of absence in 2009 to go work at the White House, where my primary responsibility was to design and build the Affordable Care Act website. I'm just kidding. That wasn't my main function. I just wanted to make sure you guys were awake. So what I did do there, though, was work on a variety of healthcare issues. And like everyone in this room and my colleagues on this panel, was able to see not only from a former clinician's point of view, but from a policy perspective at a high level, indeed how broken the system was at virtually every level. When I left the White House in 2011, I went to go run the merger of a company called Nighthawk Radiology and Virtual Radiologic, which did teleradiology started in about 2001, in an era when the idea of a cardiology or radiology exam being read from afar was a crazy idea. And over time, grew that company to see about 9 million unique patients every year. And in looking at that business, I just saw internally incredible changes in service. Getting a diagnosis, instead of it taking a week, taking 20 minutes. Having a cost structure that was literally 25% what it was in the brick and mortar world. And from a quality perspective, an ability not just to measure quality much more effectively, but to make changes much more accurately and faster to get that quality improved. So a few years ago, we started Doctor on Demand, allows patients to instantaneously video connect with a doctor or a psychologist. Very much echo Roy's comments, and we've seen a great deal of adoption in the health plan space, the health system space, and certainly the employer and retail space. So looking forward to the dialogue and discussion. Thanks.
Great. Good afternoon. I want to first compliment all of you for hanging out here on a Friday afternoon to hear the session. I really enjoyed kicking off the session and introducing Joe. And by way of background, as you probably know, I'm the Chief Medical Officer of Walgreens, and we've been in the news just a bit the last few days, which has really been interesting with the proposed merger with Rite Aid. As Chief Medical Officer, I'm kind of continuing the work I've done for 25 years, which is really around my passion of finding large populations of patients that have a problem, whether it be diabetes or heart disease or asthma, or folks who are just trying to address an acute need and find new solutions to meet those needs at scale. And the exciting thing about Walgreens, of course, is one of the things we have perhaps more than anyone in healthcare in America is scale, with these thousands of stores and thousands of pharmacists and clinics, and now with our digital presence being an extension of that. So for the kind of things that I'm going to be talking with my colleagues about today, I see telehealth as a natural extension of the convenient type of support that our pharmacists and our nurses give in a bricks and mortar way in our store. We're utilizing telehealth tools, either ones we build ourselves or with partners, digital health companies, to provide those services. So it's really all, for us, it's really all about convenience. And in this day and age, convenience doesn't mean just being on the best corners. It means being everywhere and anywhere consumers want a service, whether it's with a pharmacist or a doctor.
Okay, thank you. I'm going to ask a few questions, and I'm just going to pick randomly someone to start. So Pat, I'd like to ask you to go first, and then we'll just work our way down and then back to Harry. But my question is, there are a lot of myths, and we had a great conversation when we were planning this panel about these kinds of services and approaches to care. And one of them is that you all only provide care to the worried well. That people that really need to be actively engaged in chronic disease management or have complex conditions, these kinds of services and programs are not really helpful to them. So I'd like each of you to talk a little bit about the types of patients that you most commonly take care of. And having looked at all your websites, I'd also like to hear a little bit about what kinds of services you offer to non-English speaking patients. Okay?
Sure, absolutely. So in terms of the patient populations that we serve, I've been very pleasantly surprised with the breadth of demographics and socioeconomics of our patient population. From an age perspective, we've taken care of patients on their own. I mean, without a caretaker helping them with the mobile app or the website. Patients in their 70s and 80s. Parents calling in for children, as young as a few months old. Probably our most popular user tends to be parents who use it for themselves and also, for their children. There used to be a common sort of idea that telehealth was only useful for, for instance, rural areas. I think that time is no longer true. You'll hear various statistics, but the average appointment time nowadays to get a physician's appointment has been quoted around 21 or 22 days. In the suburbs of Chicago, the suburbs of San Francisco, just because you have insurance or just because you're well off or even in a suburb doesn't necessarily mean you can get in. So rural, urban, suburban, we see patients from all of those various areas. The types of conditions certainly are going to cluster. We've treated over 300 different types of diagnoses, but 80% of them are going to fall into a top 10 category, which are very similar to the reasons people go into emergency rooms, urgent cares, and primary care offices for acute visits. Upper respiratory infections, urinary tract infections, rashes, musculoskeletal injuries. So, do we get some calls from the worried well? Do we get some calls from, we'll pick on a suburban soccer mom? Sure. But that should not be discriminated against because they also have a barrier to access. But at the same time, we get, a diabetic or a hypertensive who is traveling to another state, and perhaps they forgot their medication. And they're calling in to get care, across their home state. We help out patients like that. So the types of patients, is very mainstream. It mirrors an American population, if you will. And given that I think the goal, certainly of all four of us on this panel, is to help improve access, truly improve access to care, I think we're doing a pretty good job of doing that across multiple patient populations. All that being said, I think there is a tremendous opportunity to do more in telehealth in the more chronic longitudinal space, which is obviously where a brunt of dollars and pain points in the American health system reside. And I think, we'll see more of that. So there's certainly more room to care for a broader base of population, but right now our demographic is pretty far and wide. Lastly, on the language piece, we cater to English and Spanish speaking predominantly, so our service can be accessed on demand or through appointment. And so if you connect immediately, we cater to English and Spanish. For other languages, whether it's German, French, Hindi, Cantonese, or others, that has to be done through our customer care center to set you up with an appointment with one of our physicians who can do that. We are actively trying to deliver more care in certain underserved populations and non-English speaking languages. As somebody who was a full-time policymaker and still serves on some government boards, I think that's a tremendous area of improvement for us, is to care for more of a minority population.
Okay, thank you. Roy?
So I would say this. I don't think that it's terribly interesting to know the mix that American Well as a company serves. I think if anything, what's interesting is how that is changing right in front of our eyes this year. And there's a reason for that. I think the term telehealth has been hijacked. And if we can't do a show of hands because we can't see you because of the lights, but most people think of telehealth as a way for a patient to quickly get in front of a physician, whether it's a minute or 2 minutes or 5 minutes or 10 minutes, really doesn't matter whether it's a telephone or video. I think we all agree that video is better, but that's not the point. The notion that telehealth is that function. It's a quick fix for a patient to get in front of a physician, usually to get simple medication for simple primary care issues, has kind of become the norm. And people price telehealth and they think about the value of telehealth in that context. Now, don't get me wrong, if someone has the flu in the middle of the night or has a UTI, that's a very, very upsetting condition, and getting cure for that is great. And for most of our lives, probably about 8 years of our existence, this has been most of the traffic that we've seen, and it's terrific. It keeps the lights on. But we all understand that this is a tiny, tiny fraction of healthcare. I mean, if you think about healthcare dollars being spent and the pain involved in healthcare, it's not the flu and the rash and the UTI. It's the diabetes and cancer care and a variety of chronic conditions and all of that. And I hope you're unlikely to try to deal with your cancer by going on your iPhone at 11 o'clock at night to see who can help you. That's not the way healthcare is being done. So there is another part of telehealth that we all kind of conveniently forgot about, which is the part where telehealth serves not in the hands of patients to immediately find someone to talk to in the middle of the night in 2 minutes, but rather serves in the hand of the people that we regularly trust to care for us, which are our physicians, with whom we actually have a relationship, with whom we have a long-lasting interaction to deal with conditions that we actually have to deal with and are challenged with for a long period of time. With the arrival of telehealth in the hands of physicians, not in the hands of patients. So we're now, in the last 2 years, we've invested, I don't know, $60, $70 million in developing that capability. With the arrival of telehealth in the hands of physicians, literally the ability for them to say to their patient, Mrs. Jones, your diabetes is going, haywire. We need to actually keep tabs on that. We're actually going to touch base with you every other day to make sure that your oral hypoglycemics or insulin or whatever it is right. You don't have to come to the office. You don't have to set an appointment. We'll just touch base with you through this. That now allows a completely different scope of healthcare to be delivered to patients in places where they need it, where they have difficulty leaving their homes, where they need kind of that better enveloping. And the moment we started offering those capabilities to physicians and hospital systems, the pool of ICD codes that we started seeing on our system has radically changed. And today we're seeing heart failure and cancer and diabetes and asthma and those surfacing way more than anything else, because if you think about it, hopefully you have the flu once a year or twice a year, or hopefully not.
If you get your immunization at Walgreens, you won't get the flu at all.
Walgreens, of course.
Just a commercial.
Or Rite Aid, which is also Walgreens. Anyway, but the reality is that there's so much more healthcare that happens in those domains. Telehealth can serve an enormous role in the hands of physicians to care for their own patients. And because that is the new telehealth that we primarily see happening and being purchased and adopted and deployed, we're seeing a lot of chronic patients that are using telehealth.
Okay, thank you. Mark.
Dermatology is clearly a different specialty.
Yeah.
Where patients themselves are very self-aware that they have a skin, hair, and nail problem. And unlike some of the live platforms, 88% of all dermatologists that are doing telemedicine are doing what we offer through our platform, store and forward technology or asynchronous conferencing. So the patient can come in anytime, anywhere, report data, images, and then send it to the dermatologist of their choice. And it's really what we're aiming to do is enable choice, really unimpeded access to services, and now offer patients a broader range of clinical services. And I would agree with Roy that as healthcare providers, as dermatologists, we're all stressed and strained and trying to figure out ways that we can take care of more people, provide better timely access, even to our own established patients. Some things that we've been learning over the last couple of years is that females clearly outnumber males as far as users. 60% are under 40, so it is a lower age demographic population. But interestingly, 58% of the visits that come through our platform come in between 8 and 4, the typical workday hours. So it's the convenience factor where people don't have to miss work, travel, take their kids out of school to get care. And the other interesting thing that's happening in the population right now is the skin cancer epidemic. And we're all being made aware through various media campaigns about doing spot checks. And we're learning that about 15 to 20% of patients who use our service are using it because they're concerned or they're worried. And this is an opportunity that now dermatologists can better determine how they're going to use these very valuable in-office slots for patients. And so the overall, I believe, as far as our discipline and specialty, that for us to kind of survive in the healthcare market, to remain strong and autonomous, it's to be able to provide better access to patients. And that's what we're aiming to do with this store and forward platform.
Thank you. Harry.
Yeah, we're a little different because in terms of the question of the worried well, because we see everybody, right?
Yeah.
So 6 million Americans walk in. I'm not going to talk with the Rite Aid numbers yet because I don't know them. But from the Walgreens perspective, 6 million Americans walk into a Walgreens store each day, and 2 million come to either our website or our app. And we have the #1 healthcare app in America, the Walgreens app. It's the #3 retail app, behind Amazon, because people use it to refill prescriptions or send photos to the photo shop at Walgreens and to do pill reminders and things like that. So just by sheer volume, we see everybody. The other thing is, because many of those people, if not most, are going to come to our pharmacies, by definition, they have illness. Worried well don't generally get prescriptions. At least doctors tend not to give prescriptions to the worried well. Sometimes they do, maybe vitamins or something. But so by definition, the people we see in the pharmacies and the clinics have real illness. And then the final question about sort of diversity and serving diverse populations, we're very proud of this. Greater than 50% of our stores are in lower income, diverse neighborhoods. And therefore, we've developed community leaders and folks in those stores that cater to diverse needs, both not only from a linguistic standpoint, but also some other issues. One quick example, as I wrap up my comments on this, are we have 800 pharmacies that are HIV/AIDS centers of excellence, where the pharmacists receive special training, not only in the drugs, and the drugs are available, always in stock, but on the social issues and how to be sensitive to folks with the illness. And because of this service, in many of these communities, a huge percentage of patients who have HIV/AIDS are going to our pharmacies because of that kind of customized program. So we're a little different, I think, just because of scale. We kind of represent America.
Great, thank you. I'd like to start with Mark this time, and I'd like to hear about how do you monitor quality for the services you deliver, clinical quality, and also what kind of feedback do you systematically collect feedback from people that use your services about their perspective on the quality of care they get?
Sure. So as Chief Medical Officer, I've developed a quality measures program for Iagnosis that really looks at patient satisfaction, our provider satisfaction. We do route consults to the patient's primary care doctor, so looking at PCP satisfaction. In addition, developing the whole process or architecting the ability to look at grievances, having myself as the Chief Medical Officer look into cases where there's complaints that come through our 18/7 call center, and really to try to develop a process organizationally within Iagnosis that looks at the quality of care given by our doctors. Are they meeting the service level agreement that patients are attesting that they would like to receive care within 3 business days? We certainly developed our own internal credentialing that basically aligns with how insurers credential providers, having the correct documentation, and especially during the renewal periods. The interesting thing is, unlike primary care, where there's HEDIS scores and other measures of quality, that really doesn't exist in dermatology. So the fun thing for me as Chief Medical Officer is really developing a set of metrics where when we look at the types of data that patients are giving us and we see that they're sunbathers, we can provide some quality measure counseling as part of the platform just to bring a better awareness to patients as far as what are good behaviors and how to do self-exams and how to do self-monitoring. So it's multi-leveled approach, and we're really going to be looking to implement this, over the next 3 to 4 quarters.
Okay, thank you. Roy?
Sure, I would agree with Mark in saying that when you talk about quality, it's like an onion. There's a lot of different dimensions to it.
Yeah.
I would say from an experience standpoint, we really have to, when we think about what we do, we're delivering healthcare through different channels. So it's not only the quality of the interaction, the experience, also the physicians and the care that is being rendered. From an experience standpoint, the way we look at quality is that we've actually baked feedback into every one of our transactions. You cannot, as a patient, finish a transaction on our system without actually giving us feedback about how good was your experience and what did you feel about the physician that gave you care. And we live and breathe by transparency. So we make that information available to the physician, we make that information available, obviously, to other patients about what they said about that physician. And of course, we take to heart anything that is under 4 stars. Every one of those cases gets investigated. From a clinical quality standpoint, so we have dual lives, right? So a small part of our business is actually what, is like what Dr. On-Demand is doing. That's kind of the direct-to-consumer piece, where we actually have physicians who are doing peer review one to another. We have a clinical quality control group that looks at it, and maybe the best way for me to give you a sense is that most of the Blue Cross Blue Shield plans we work with, which are over half of the country, have actually scrutinized us and to the point that they delegated credentialing authority to us. Mm-hmm. So they trust us to pick the physicians to go on their network. And that kind of gives you a little bit of sense. And then last but not least, the 95% of our business, which is delivering telehealth capabilities to health organizations. So, Cleveland Clinic is an example. What we do is we give them a platform to do what they do regularly. So obviously, it's anybody's guess what you think about the quality of the Cleveland Clinic. They're good enough, and we don't question that.
Okay, thank you. Pat?
Sure. So for us, it certainly is an end-to-end view of quality. It starts with a rigorous picking and screening of physicians. We've literally had thousands upon thousands of physicians apply. We then will interview them, screen them, take them through a much more rigorous screening process than I have credentials at several hospitals around the country and at a much higher level of credentialing, frankly, because when you're sort of pushing the envelope in an innovative sort of care, I tell people every game is a road game. You need to be doing it better and cleaner than happens in regular medicine. We, through great pain and expense and time, we employ our physicians, which allows us to have incredible quality control, direct management over them. And then we deploy an incredible amount of data. So without mentioning any of my former institutions, of which I'm very proud of, and they're like several of the hospitals here in Boston are top U.S. hospitals. At those places, I could have worked next to a colleague who they might not have known how good of a doctor I was, or vice versa. But one thing that we do at Doctor On Demand is we're incredibly quantitative. So, for instance, on our patients, on our behavioral health practice, we are measuring longitudinally their GAD-7 and PHQ-9 scores to make sure those are indeed decreasing. As my colleagues to my left mentioned, we are instantaneously monitoring patient feedback, which allows us to determine, indeed whether there was a problem with that consult, whether it was our own doctor or one of our healthcare or hospital system partners. And then on our physician side, between physician peer review, double-blind peer review, and a variety of metrics, their antibiotic prescribing rate, their percentage of generic prescribing rate, wait times, other durations, we have at our fingertips instantaneously thousands of data points which we are able to not just share with the physicians but constantly apply as a metric for self-improvement. And by having our doctors employed with us and seeing more and more cases, we deploy a great quality mantra of sort of the focused factory approach. The more you do it, the better you get, and the more you're able to internalize the feedback of your performance and continue towards a path of perfection. So those are some of the things that we do to ensure very high quality and quality control.
Great.
Yeah, so we're a little different because we have different types of professionals in Walgreens. The most numerous are the pharmacists. So we have 25,000 pharmacists in the U.S., and they're not really making diagnoses, right? Because that's not their board cert, that's not their licensure. Once a diagnosis is made, they can support patients and work on adherence and help with lifestyle issues, but predominantly they're helping with medications. So since Walgreens has been at this for, 115 years or so, we've developed really good processes of hiring the right pharmacist. They're all certified by local state boards. We have great training programs online. We have tools in our computer systems that guide them about drug-drug interactions and when to look for problems and what to counsel patients about. And we do collect satisfaction ratings, obviously, from our customers. Now, in our clinics, where we have nurse practitioners, they truly are making diagnoses and treating. We do actually have, because it is, some of it is primary care, we do have some HEDIS measures, quality measures that the health plans use for things like how often antibiotics are inappropriately used for sore throats or for bronchitis. And we do audits of their charts because it's on electronic medical records, and they have supervising physicians that do a certain number of audits of their charts as well. And then for our telemedicine program that's still relatively new, it's less than a year old, that we do with MD Live, they have programs that are somewhat similar to my colleagues here, and they have their own quality oversight programs. But we've participated deeply in how they do quality. We've reviewed it. We've made some suggestions. Many of the things you heard today are very similar, but it's not really our company, but it's our brand, so we're very invested in making sure the quality is top-notch. But we're a little more of a diverse business in terms of different types of professionals interacting with patients and customers.
Great. We've just got a couple of minutes left before we're going to open it up to questions. But one thing, in looking at all your websites, you all have different types of relationships with traditional healthcare organizations. And I often wonder, when I think about the services you deliver, why we aren't partnering more effectively to increase access, increase our own capacity, and help us coordinate care more effectively. So I'd like to hear very quickly what you think some of the ideal attributes are when you partner with an organization, a traditional clinic, healthcare system, whatever. You don't need to name names, but I just would like to hear, if you designed your ideal relationship, what would it incorporate? What would it look like? Roy?
Oh, I'll be brief because of time. I think, business-wise, obviously, we have partners that we think are unbelievable and terrific and forward-thinking and really change the landscape of healthcare through telehealth. And there are partners that are a little bit kind of follower and everything else. I think it will be a mistake to take from that and say this is a good partner and this is a bad partner, because it really depends on the personality of whoever is at the helm of that ship. I mean, it's all about people at the end. The one thing, however, that I would say is that I don't think, unfortunately, if we really want to see telehealth deliver on its value and its promise, we have to do the less popular thing, which is to understand you can't choose the partners. If, like a patient, if we came to you and said, who do you choose, the delivery side of healthcare or the health plans? Well, there's no choice, right? I mean, you get your health insurance that allows you to go to the delivery side, and then you go to the Walgreens to fulfill the medication. You actually have to work as a patient with everybody. And if telehealth is just the digital way of delivering healthcare, it actually has to be immersive, inclusive. You have to do the heavy lifting to actually reconcile financial claim eligibility with the payers. You have to work with the workflows of physicians. You have to tie into EMRs of health systems. You have to do electronic prescribing with Walgreens of the world. You have to document in a way. You have to submit yourself to the scrutiny of government business because you want to work with Medicaid and Medicare. And I can go on and on and on until I'm blue in the face. Unfortunately, and fortunately as a business, if telehealth is modern channel for healthcare delivery, you don't get to choose. You got to work with all of them.
But when you work with all of them, what makes it work well? When you work with a health system, can the physicians or the other clinicians in that system actually access the records that you're keeping?
Yes.
Is everything coordinated?
Absolutely, and this is where many, many hundreds of millions of dollars go in to do that very unpopular work that doesn't get onto USA Today and Wall Street Journal, New York Times, tying into the backend system, making sure that everything goes smoothly. All of these things are necessary evils. They are evil. You know that. I mean, many of you know that. But you have to do that. And if there's one factor that makes a difference. It's not the electronic medical record system, it's the leadership
Yeah.
that sits in front of those organizations.
Pat, you look like you're
Sure.
going
Yeah.
to say something.
You know, I'll keep my comment brief because of the Q&A, but my answer would be very, very clear. I think the ideal partnerships is the best hybrid between in the cloud and on the ground. There are some incredible benefits to digital health, telehealth, just like in every service, but the marriage between the best partners on the ground, because so much of care in the next 10, 15 years is still absolutely going to require a physical visit, into the doctor's office. That is going to be the vast majority of visits going forward still. And where you can do telehealth, that should be done, such that the cases that need to come in can be handled properly. So partnerships with excellent health systems, partnerships with excellent retail pharmacies that are the best at what they do, combined with the best of in the cloud, I think is the ideal partnership.
Great. Here.
Yeah, I don't have a lot to say other than you should pick health systems who have the word partners in their name.
Okay.
That's a Friday end of the day comment. Yeah.
That's a Friday end of the day comment, but do you?
No, but seriously,
Yeah.
real quickly, I think I get to speak to a lot of health systems and meet with them, and there's sort of two philosophies. Philosophy one is a desperate desire to preserve fee-for-service volume at all costs, and to keep care in the high-cost setting of the hospital, the emergency room.
Right.
And model two is realization that the forces of value-based purchasing and a shortage of primary care doctors and consumerism with people with large deductibles where they need to find cost-effective ways to get care is driving us to really figuring out, like Pat said, who does what best, and really realizing that the consumers want solutions that are convenient and cost-effective. One real quick story. When I talked to one hospital executive in a meeting said, it's really annoying that retail pharmacies are, taking a lot of the patients away that we could be seeing in our hospital. And one of his board members said, well, if you could get your docs to work after 5 o'clock on Friday afternoon, maybe you wouldn't have that problem.
Yeah.
So this idea of people adjusting and being convenient, being accessible really is an issue.
Okay, Mark.
I echo the comments of my colleagues. I would just add one other thing. I think one of our ideal partners in dermatology is, or an ideal attribute is the patient themselves, being a different specialty. And, what we're learning is people want choice and they want convenience. And in dermatology, we're finding that based on our outcome surveys following each visit, about a 98% patient satisfaction rate. So I believe that the ideal partner is the patient, providing tremendous value, improving societal costs, providing an access point to care that they don't otherwise have. And right now in the country, about 65% of all paid skin visits are not going to dermatologists. So if we develop this very tight partnership with the patient or consumer of healthcare, I believe that's going to really propel dermatology. I would just like to also add that, Highmark Blue Cross Blue Shield in Pittsburgh was one of the first insurers to make store and forward direct-to-patient teledermatology a covered benefit. So I think having forward-thinking payer partners who understand the pressure points and the complaints that patients, their membership has regarding accessing the skincare, having those partners is important to us too.
Okay, thank you. We're going to open it up for questions. It's a little hard to, you're in the spotlight.
I am.
Oh, go ahead.
Hi, I'm Deborah Randall. I'm a telehealth attorney and a big supporter of where we're all going in this field. One of the criticisms I hear is that the kind of service that you're rendering, at least several of you are representing on the panel, the physicians who are part of your panels never hear what happened to that patient subsequently. So the question is, how do you really measure quality if you don't know what happened to them afterward and whether or not your physicians made a good call or didn't? That's the first part. And the second is sometimes the criticism is there is not a consistency with the ongoing relationship with the PCP. some of what you said suggests that's not your model, but I'd be very interested in what your feelings are about, isn't quality also measured by what happened to the patient subsequently? Therefore, how well did your doctors do?
Thank you. I had actually the same question. So you want to start, Pat?
Sure, absolutely. It's a terrific question. So on the first part of the question, that feedback loop.
I'm going to ask everybody to be very brief so we have
Great.
time for some more
The
questions.
follow-up part is so critical, and so what we do is at least two fundamental things. Is we follow up directly with that patient to ensure that if we refer them on to further care, that they indeed got that further care, and if we essentially coded that case as diagnosed and resolved, that they are indeed resolved. We also, through our partners, which are health plans and health systems, we partner with them longitudinally to ensure that that patient didn't go on to another visit, didn't indeed get that UTI turn into a pyelonephritis of their kidneys. So that part is very relevant. Now, to the second part of your question, there is in part of our model, the non-chronic care part of our model, there is a urgent care-like aspect to it, and it's not identical to primary care. So it's much more like going to a brick-and-mortar urgent care center, and that paradigm, I think, needs to be remembered in the context of an American population that, unfortunately, I wish I could wave a magic wand and say that everybody had a primary care physician that was open 24/7 that followed up with them directly. But we always aspire for here, but we consider the sort of baseline, what happens in real American care. And in brick and mortar urgent care, sometimes these patients don't have PCPs, and when we have those patients, we find ways to try and follow up, but it's not perfect.
Anybody else want to respond?
I'll just, echoing everything that was just said, I would only say that, funnily enough, if you compare what we do to the urgent care centers and the emergency rooms, because all of the interaction that happens on our system is actually digital, it means that we actually capture sometimes better documentation and better understanding of what happened in the telehealth transaction. That information is then handed over to the patient. And I think, and it's the same on Doctor on Demand system, the patient can actually choose to follow up with either the same physician or with another physician, but at least they come armed and dangerous with full understanding of what was, what the diagnosis was, what the care was, and they can continue with that. In all cases where the system is being used by physicians and their own patient, that question is moot because it's just part of the way they do follow-up.
Mark?
Just to briefly add, our system is not a one-and-done transaction with a patient. Our network providers provide access and continuity for a full 30 days after the consultation is completed. We also provide the ability for the consults to be routed back to the patient's PCP. And we also survey members, and we have about a 28% survey response rate to gather feedback on what we're doing right and what we're doing wrong. And I think generally when you have that high of a response rate on surveys, you're either doing something really good or really bad. And so far, so good.
I'm going to go over here.
Hi, my name is Astrid Bihari. I'm a management consultant, and I really enjoyed the discussion. My question is, if we look at all the telehealth players today, overall, you probably generate less than $500 million in revenue per annum. But if I look at what the Wall Street analysts are predicting, it's going to be a $20 billion industry in 5 to 10 years. And so I'd love to hear your perspective on what's really going to tip the scales for telehealth.
Who
Thank
told
you.
you we're making less than $500 million revenue? Short answer, chronic patient care. Right? There's only that many UTIs that you can treat and bronchitis that you can treat. Unfortunately, there's a lot more healthcare needs, and when telehealth steps into that domain, it's many, many orders of magnitude, and it's actually happening in front of our eyes.
I'll agree very much with Roy's answer. Chronic care is the deep end of the pond. The second thing is, this is such a new industry that as a management consultant, you'll know marketing very well. There is still a lack of primary market awareness dramatically. So Roy's company and my company, I think we've been very successful, but we're relatively nascent. So when we talk on the order of 10, 20 million people that have us covered and used, that sounds great. That's still less than 10% of the American population. So, I say that most people haven't even heard of telehealth yet. This conference clearly does, but out there, people don't even know it exists. So there is a certain organic growth rate that in 5 years, people will know that this is even an option without Roy or myself having to advertise and tell you that it's an option.
Yeah, I'm going to be a little bit of a skeptic. I definitely think it's going to grow. I definitely think it's going to be a major force, telemedicine. But the kinds of numbers that are being thrown out don't seem reasonable to me. Even the number you threw out, you said $500 million. That just doesn't make sense today. With you add up the number of telehealth visits that have been done, I think some of the analysts are throwing in things like teleradiology and tele-ICU, and not the sort of telehealth we're talking about today, where it's a doctor talking to working with a patient in the community. So although I think it's going to grow, those numbers seem, at least from where I sit, to be radical.
Going to go over here.
Hi, my name is Anant. I'm an internal medicine resident at the Brigham. My question, just to kind of dovetail off the last one, is how you guys, as you run telehealth organizations, how some of these trends relate to your ability to build relationships with the patients themselves. As I understand it, it seems like you're transitioning from a model where you're serving patients in an urgent care model where you can kind of market to them directly, to more of a model where you're trying to do chronic care, which requires you to embed yourselves within the infrastructure of health systems. So do you see the future of this industry being, your organizations are essentially middleware for health systems, and American Well and Doctor on Demand are essentially invisible to us as customers? Or do you see there sort of being another opportunity for you guys to build an independent brand and to own the relationship with the customer, the patient, outside of the health system?
Very briefly, more than 95% of our business is not carried under the name American Well. That's for a reason. We strongly believe that patients are not going to start acquiring services from a software company. We don't think that it needs to be the case. And that's why most of our activities are under the brands of the organizations that we serve or the physicians the patient know. And I think that's, if anything, our mission, that's a little bit of a paraphrase here, but our mission is to actually make telehealth and telemedicine disappear. Yep. It needs to become medicine. And we are, call it a middleware or whatever it is, we're an enabling technology to foster and expand on the accessibility and the relationship between patients and physicians. That's what we're here to do.
Yeah, very quickly, agree certainly that, we want that prefix to eventually go away and improve care sort of irrespective of who it is. That being said, we see ourselves as a health system in the cloud. We are a medical practice, and our goal would be that, at some point in the future when a patient has a medical problem, we are an option for them to come to at least begin that journey of where to go. Now, that journey certainly may end up at their respective healthcare system. It may end up, with us referring them to you personally or you being on our platform. But we want to give all of America a first option of where to turn to with the healthcare problem that they have.
Yeah, Mark and Harry, if you have anything to add, because I think we're out of time, although the clock's now giving us more time. So go ahead.
No, I would just add that, our goal is to really provide, for example, dermatologists just a tool or a method that acts as an extension of their practices where they already have relationships with patients, and then to further extend that, as Roy had mentioned, with a private label opportunity where groups or entities, because dermatology is now consolidating, the mom and pop small practitioners are becoming parts of large groups which market and brand and want to have awareness on what they offer. So we're the tool and the method to enable that connection between the patient and the provider.
Harry, do you have any last comments?
Not on this topic, no.
All right. Thank you very much. Thank you.
Thank you.